Good evening, dear ladies and gentlemen. A very warm welcome here from Frankfurt, from the 96th German ENT Society meeting. Welcome here in the room in the lecture hall, and welcome at home in front of your PC. We are very proud to announce our quarterly hearing meeting here live from the German ENT Society meeting, and I'm very, very happy to tell you a little bit why we are here and what we are doing. We present the hearing group. The hearing group is a compulsory group of about 33 ENT departments worldwide, and we are founded in the year 2008 from Würzburg, Vienna, Antwerp, and Warsaw. And we are here to bring hearing implants to all over the world, to the people dedicated to work. We are together a group of researchers. We are a group of surgeons, of physicists, and all types of therapists, speech therapists, language therapists, and teachers. And now we have this wonderful round table here in Frankfurt, and we are very thankful to our president, Professor Timo Stöver, here from the ENT department in Frankfurt. It's a premiere. It's the very first time ever that there is a hearing meeting at the German ENT Society meeting. Yes, and we will start. And now I pass the word to Professor Gavilan. So we will fly to Madrid now, although it is here in Frankfurt.
Teletransportation, yeah. No worries. So here I am, and I'm so glad to see you all. And as Professor Baumgartner mentioned, this is an interactive session. Our roundtables are interactive. This means that we want you to ask questions, and we want also the people connected, if we can have them, to also have their questions. The idea is to have 5 different presentations of 5 minutes each, so that we can discuss after that. And if we can travel to the next virtual place, we can go to St. Pölten in Austria to meet Professor Georg Matthias Sprinzel. The topic today will be current challenges in hearing implantation, and the first challenge will be presented by Professor Sprinzel. As you probably all know, he is the professor and head of the Department of Oto-Rhino-Laryngology, head and neck surgery at St. Pölten University Hospital. He focuses on all types of surgical hearing rehabilitation, as well as on neurologic and oncologic skull-based surgery. The hearing group is really honored to have Georg among one of our distinguished members. And today he will deal with one of my favorite topics, which is, come here, bone conduction versus middle ear implants. Georg.
Javier, thank you very much. It's a big pleasure to be here. To bring it down to 5 minutes, you have to be very quick and fast forward striking. So I will try to do my best. In the lounge in Vienna, we started to prepare this lecture, and I was talking about apple and pears. So we're talking about apples and pears when we compare bone conduction implants against or versus middle ear implants. And nevertheless, I will try to work out and point out the differences between both systems. So the vibrant sound bridge, in my point of view, it's a precision playmaker, the top midfielder in the middle ear, direct to target accuracy, direct stimulation of the middle ear structures, reliable under pressure, excellent reliability and long-term performance data, versatile and adaptive, can play in different field positions, and also team-oriented, works in harmony with other players, especially PMIs, And well, you know the player. It's like Lionel Messi, usually a guy from Argentina who ended up in Spain when he started at the age of 13 years. The bone bridge is something like a power forward and a striker, unshakable stability, firmly anchored and always in position, built to last, fair player, skin stays intact, direct to target drive, direct stimulation of the temporal bone, tough but flexible, robust design with surgical flexibility, and also team player, no diva, particularly easy to work with. Maybe you know the player. I think it could be Erling Haaland. He's playing now for Manchester City, one of the best strikers in the world. Now to my personal experience, I've done roughly over 400 vibrant sound bridge surgeries. The majority of the indications were sensorineural hearing losses, but I had also roughly about 35% mixed hearing losses, and the other two indications were atresias and otosclerosis. The surgical options we have for this group of patients are well known, so we can easily put the bone conduction FMT on the long process of the incus, or on the short process of, or on the head of the stapes, like in this malformation case. Here we put it on the round window in the Coletti technique. This was here a special coupler which was newly developed some years ago, where we could place the FMT on the head of the stapes with a special encoupling device. And of course we can use the device also for the treatment of otosclerosis, and the surgery is called power stapes. When we look to the outcomes, so we have very good functional amplification, and when we compare the unaided and the aided situation for the classical application on the long process or on the short process of the sound bridge, it's a very good range where we end up at 80% correct recognition scores, and when you see the unaided situation at 40% or 30%, it's a huge benefit for the patient. This works also for the Freiburger monosyllables, and here we have the data from the round window applications, and we have here also a huge benefit for those patients. Those data were published in the laryngoscope and audiology and neuro-otology, and this is true also for the bone bridge scores. So we have very good amplification rates and void recognition scores data compared from the unaided to the aided situation, and this is truly important for the adult and also for the pediatric population. And we compared also here the speech recognition scores in quiet, and we have here also a huge benefit for all the groups, and also this paper was published in the European Archives. So what are setting these two systems apart? Here, this is a patient from Hamid Reza Mojalal, and he did compare the bone conduction implants versus the vibrant sound bridge, and we see that a different level of hearing loss. Of course, the vibrant sound bridge performs significantly better than the bone bridge, and he compared 24 vibrant sound bridge patients versus percutaneous bone conduction device patients, and especially below a level of 35 dB, we have a clear benefit for the patients with the vibrant sound bridge. So the vibrant sound bridge outperforms bone conducting hearing aids which have a hearing loss more than 35 dB. Yes, so I will overgo this in terms of time sparing. The localization performance, bone conduction versus vibrant sound bridge. We have very clear data that especially the bilateral vibrant sound bridge has a better performance. You can see this here on the plot compared to the bilateral bone conduction devices. And here we have a superior localization ability compared to bilateral bone conduction devices. This is quite clear from the tests, which, and this study was done by Achterberg recently, it was published in Trends in Hearing. So coming back to the match verdict and the player rating, bone bridge provides a great audiological outcome. It's a robust device, and the surgery is quite easy and straightforward. The vibrant sandwich offers more gain than bone conduction implants per se, and it offers also better localization due to the pure ipsilateral stimulation. But however, both systems together offer great surgical and audiological flexibility required in personalized medicine. Thank you. That's it for the moment. And I invite you to the Osteo 2025 in Vienna, shortly September 3rd to 6th. Thank you.
Thank you, Georg, for being on time. We are going to keep our discussion, 10 minutes discussion. So, well, I enjoyed very much your presentation, the analogy of football. The only problem is that I don't like the players you put. I mean, you have Jamal from Spain and Mbappe, so it's a little bit old-fashioned. Anyway, I have a couple of questions just to start. Is there any situation when the only thing you can use is a sound bridge?
Yes.
Which is it?
It's a situation when you have a patient with a radical cavity and a bone conduction loss more than 45 dB. You will fail then with the bone conduction device. And this is true for all bone conduction devices, independently of the brand. So you need to have something more powerful to have a functional overclosure in those cases. And this is the perfect indication, in my point of view, when you have a patient with a functional deafness, but still with a inner ear which is working.
Excellent. And the other question is, which is the most elegant situation for a bone bridge, for a bone conduction device? Just the other side of your presentation.
Well, good question. I would say that when you have a patient with a good inner ear and for whatever reason with a huge conductive component. And of course, the indication may differ from let's say you can have a chronic ear, the empty middle ear where you don't have the chance to reconstruct the ossicular chain. Let's say you have 3 or 4 failed tympanoplasties or the foot plate is fixed. But if you have a very good bone conduction hearing, very good inner ear hearing, then I would prefer to put a bone conduction device.
Okay, I have a question from the online audience saying, when intact ossicular chain, which coupler do you prefer, long or short process?
So I have a preference for the long process coupler. I like to see the intact ossicular chain.
Long process?
Yes, long process.
The other?
I also prefer a long process, but sometimes there is not enough space, and then we choose for short process, because from our audiological data, it went that it's a little bit worse short process connection, but in general, honestly, it depends on the surgery, because quite often, sometimes you can have very nice connection, sometimes you have not a nice connection. So always when we have enough space, we go for a long process, but it's not majority.
Baumi, short or long?
Of course, long. Actually, the short process was an idea because of the couplers and to make it very short. The long process surgery can sometimes be quite tricky, especially with the couplers we have since November 2019, because now we have not the old clip we had from 96 to 2014. The new clip since 2014 is a little bit bulky, and it can be sometimes quite narrow. Generally, we see in our results, honestly, not a significance that the long process is better, but we see a trend. We see a trend that the long process is better, but not a real significant calculation. On the other hand, the short process was quite convenient because now it opened the space for many, many more surgeons because it's much, much easier to operate. So the short process can be done actually by a well, let's say, older resident. Yeah, he can do that surgery. And we hoped that with the short process, this will boost the implant generally. On the other hand, the short process has the advantage that a power stapes, for example, is much, much easier. So you can have the sound bridge on the short process and the stapes prosthesis than on the long process. This is for surgery much easier than if you have both clips on the long process.
Well, I'm so happy to be an older resident because I'm much more in favor of the short process. Professor Rudolf Hagen, is there any microphone? There's a microphone here.
So my question to Georg is, what was the percentage between malformations and chronic ears in your series of vibrant sound bridge? Because
Malformation and?
Malformations and chronic otitis
So I
media.
have significantly more chronic ears than malformations.
Okay.
So the malformations nowadays, most of the patients are deciding to go with a bone bridge or with a bone conduction device rather than a vibrant sound bridge.
And the second, can you give a short comment on children?
Well,
to
that's
use
honestly, the vibrant sound bridge is an old device. It's more for the elderly. I have not so many children. I have a case series from roughly over 400 sound bridges, but I think I have less than 35 implantations in children.
Professor
Maybe
Dasser?
due to the fact that I intend to do not the atresias with the sound bridge.
Stefan.
And
I have a question to Georg. If you have a patient whose audiological and anatomical situation allows both, so bone bridge or sound bridge, what would be your preference usually?
well, you know, I like to do delicate surgeries. That's my personal preference is, of course, doing the sound bridge. But we have to counsel the patient also, and also the parents. And of course, you have to take more risk when you do the sound bridge surgery. So you're getting easier in touch with the facial nerve. You're getting easier in touch also maybe sometimes with the inner ear when you do round window vibroplasty. This is a complete different set of surgery compared to a bone conduction implantation. So
If you look to the German situation and look to refund situations, we have to see bone bridge is easier, is faster. I would say almost same results in most cases. And so these are also aspects we have to consider if we look, you know, internationally to not only to very specialized experts in the field, but to general ENT departments.
For the surgeons here in the room, who would prefer the short process? Long process? Well, we're tight. And there's a question from the audience in internet. And how about the risk of disarticulation of the ossicular chain?
very low. So honestly, this never happened to me. Not a disarticulation.
Okay, I have a short question.
At least not in the classical setting. So when you do classic vibroplasty, when you place the FMT on the long process or also on the short process of the incus, I never have seen a case like this. Also not referred as a second opinion.
Okay, I have a short, yes, about me, go ahead.
Barbara Wollenberg and myself, when she was still in Lübeck, we did a review paper. You can look in this after the Medline. We analyzed 2,000 soundbridge papers. And in none of those papers, in over 20 years, a single ossicular chain disarticulation was ever described. So I think we can say it's quite zero. But this is maybe related that mostly experienced surgeons do that surgery.
I've seen personally one disarticulation in one life surgery course. So it's, I think the risk is higher in regular hands than in expert surgeons. I was going to ask something, but we are running out of time. And I just want to know Georg, in your championship of the unilateral atresia, who will be the winner? Bone bridge or sound bridge?
So I think in the long run, the bone bridge, because it's easier and it's, well, easier to do. And even if you counsel the parents of the patients, when you compare the surgery between 30 minutes with the bone bridge and let's say a sound bridge, even if it's a little bit more complex case, it's 1.5 hours, all the parents are deciding to go for the bone bridge. And basically, Stefan Darze told it already, outcome-wise, it's pretty near to each other. Of course, when we go into an academic setting and when we measure the sound localization, a sound bridge may be better. But in real life, to show this, it's quite hard.
Okay, so now let's keep our journey and let's travel to Poland, to Warsaw. And we went there to meet Professor Piotr Skarczynski, who's a specialist in Oto-Rhino-Laryngology, pediatric Oto-Rhino-Laryngology, audiology, and phoniatrics. You do everything. He conducts his scientific work in the World Hearing Center of the Institute of Physiology and Pathology of Hearing in the Institute of Sensory Organs and the Medical University of Warsaw. In 2008, he filled the post of the Director of Science and Development at the Institute of Sensory Organs. We are grateful to have you here, Piotr, as one of our most active members and our vice chairman. And Piotr is going to deal with another challenge, the electroacoustic stimulation in partial deafness, the FDA approval. Piotr.
Thank you very much. Good evening, dear friends. And I would like to talk about exactly that what was mentioned. So FDA approval and the reimbursement issue. So my talk will be not as detailed in terms of the effects, speech understanding, progressiveness, different speech tests, monosyllabic, disyllabic, or sentence, but to talk about something what we have in Europe and in US was approved later. But first, I would like to start from the consensus when it was a very tough discussion. It was in Los Angeles. It was published in JAMA Oto-Laryngology when we discussion about general consensus of implants, because we see the gap between patients who could have cochlear implant and they don't have cochlear implant because of reimbursement issue, indication issue, and surgical experience issue. So there was very tough discussion, and we discussed how to define patients who could have benefits for the hearing preservation. So the statement is like when possible hearing preservation surgery could be beneficial in individuals with substantial residual hearing, we could make cochlear implantation. Why underline that? Because quite often, when I present that slide, this is our concept from my father, presented first time in 2009 in ESPCI, which was in Warsaw. You know, we have a lot of patients, but the residents, people who are coming for the training, said, Piotr, it's very nice talk, you know, Flex 20, Flex 24, Flex 28, but we will do only fully deaf patients for cochlear implantation. And that's why we try to show, okay, today, yes, but maybe in the future it could be different. And, you know, when you talk about FDA, I'm not from US, I'm past president of International Advisory Board, and we have some distinguished professors from US here. You can see the indication criteria. And you can imagine how today there is indication criteria. Not that slide. It was conference in Hong Kong when I remember discussion was never do bilateral cochlear implantation. One implant is enough. When you look in that, look, for example, in 1998 in US, there was reduced age to 18 months. Today, we know we try to make it, we do in 6 kilograms, 6 months. Sometimes, you know, 7 months. It depends, the first surgery. So we saw the progress, how it goes. So in terms of the extended indication for criteria in different countries, as that, for example, you have that, scores 50% or less in the ear to be implanted, independently of others. Today, we try to qualify patients for cochlear implants when they have no benefits for hearing aids. I dedicate that for residents, for young surgeons, and for young people in the field who are in front of us in the screen. So they are hearing. It's possible. It's fantastic benefits. This is that extended criteria. Not only for that, we can see for different countries, and that's what has changed recently. We don't only check the pure tone audiometry. Also, our center looks for pure tone audiometry, but we need to analyze progressiveness of the hearing loss and speech understanding. That situation extremely increased after COVID. When you have patients, for example, with single-sided deafness with quite nice hearing, like 17 dB in the audiogram, but they have 0% of speech understanding. That's something what we need to switch on, that we need to analyze the speech understanding. In different countries, there's different. Of course, this is the reimbursement. Sometimes we try to convince some surgeons to go on that, but I said, yeah, but we, especially from hearing aids manufacturers, then they said, okay, one cochlear implant is a lot of hearing aids. Why we should go in that direction? Because the demand from the society, especially after COVID time, much more. They work longer, live longer they would like to be active, and for them, really to have speech understanding on higher level is important. So in conclusions, reimbursement inclusion criteria are more and more common around the world to go in that electroacoustic stimulation. Not all patients will use acoustic component. Quite often, after implantation, they use only electric if we preserve it well. Cochlear implants should be proposed, this is important, for the patients without benefits. This is not end of the story. This is simple for us, but maybe not as obvious for others. Cost effectiveness is a question and request for us. We need to analyze and present cost effectiveness data for the payment of organization, because we compete with other specialty, because not we are in the ENT, but cardiologists, they underline, for example, is very well, so we need to prepare more data and more. And prognosis of the hearing loss and elderly patients become significant part. Why it's important? Because we have a very nice group of vibrant sounders patients implanted 20 years ago, and now the hearing decreased, and now we need to switch that from vibrant for the CI. I would like to invite you for our real one, the International Conference of CI, which will be in Warsaw in next year, and I open for a question. Thank you very much for invitation.
Thank you very much, Piotr. Okay, there's something I didn't get from your presentation. I mean, the idea was to mention also the FDA approval. I understand the FDA has discovered that we can do electroacoustic stimulation right now, but only with lateral wall electrodes. Is this right, or? In
general, when we analyze the FDA approval and discussion, when I ask some, there's not Professor Roland, for example, that it was only in trials. So all the patients, in general, from the past, it was in the trials. Discussion about lateral wall approval and the perimodellar electrode is the long-time discussion, and in many cases here there will be discussion about that. It's from that knowledge which I have, centers in US, they do in both electrodes. There is a lot of discussion about preservation of the hearing in long term, and that's what is the, I think, simplest answers in the preservation of the structure of the hearing in the lateral wall. Lateral wall electrode, which is straight, is more difficult for insertion. We all know, but we go and try to cover the whole cochlea. So you know, this is how it should be performed.
Baumi.
Yes, just to shortly answer your question. So FDA approved right now are only flex electrodes, flex 20, flex 24, 26, 28, and flexsoft. All other electrodes are not FDA approved.
Okay, this is
unless different clinical trials which are that. But now we are, you know, in the way. Then when there is the straight electrodes, it's commonly possible in the centers which would like to apply, and they have permission from the insurance.
Okay, well that was the idea I had. 2 or 3 years ago, the hearing group we published a paper demonstrating that was a meta-analysis demonstrating that you could preserve hearing with long electrodes.
Yeah.
Now, you are doing a case of electroacoustic stimulation. How far do you go? When do you stop? How much do you push?
You had a very nice presentation in JICA in Costa Rica about that with a lot of effects. We go as deep as possible. We can analyze that in Otoplan, for example. That's what we analyze. We analyze progressiveness of the hearing loss. So when we see that the progression is quite fast, we go deeper. Up to 28 even, and I think that the study with electrocochleography gave us a lot of answers, that when we make the proper insertion, we keep properly forces, we are delicate even before earlier, we are in good mood to even preserve the hearing with very long electrode like Flex 31. But it depends what we would like to achieve. So we look for the anatomical conditions of the speech understanding, and if you, for example, have residual hearing, and 5–10% speech understanding in best aided condition, we go almost for full insertion. But full insertion in hearing preservation is like for Flex 28 because of the size of the scala tympani in the apical part of the cochlea.
Georg, you agree?
Well, so I like to be provocative. So I would say at least you should implant a Flex 24, maybe a Flex 26, because even if you lose in the long run residual hearing, what we don't know when we do the surgery, because we do not know too much about the disease itself. We know the phenotype, but we don't know the disease, and we don't know the long run of the development of the patient. But even if the patient is losing residual hearing, he will have a very good result with the 26 millimeter electrode.
Okay.
So
that was the question from the online chat. What happens if or when the patient loses the residual hearing? Wouldn't it be preferable a regular CI with complete cochlear coverage? So would you risk preserving hearing using a 28 or a 31 instead of using a 26? Is this a good approach, or it's not a good approach? Or what's your opinion?
We published a study some years ago in otology neurotology in the group with EC, so with a better group with component, when we make Flex 20 and Flex 24. And we lost a little bit more hearing with Flex 24, but the speech understanding was even better if we lose a little bit hearing. So, that's why we want to go deeper, but not that we have very good hearing up to 1,500 and then we go with Flex 28. So then we go for Flex 24. So always when we can risk to go for longer electrode if we have proper conditions. Yeah.
Please, Tobias.
I can add from our experience, since we use Otoplan, we don't hardly use any Flex 24 at all, even for the EIS surgeries. And if we look at the insertion depth, of course, which is planned depending on the individual audiogram, we don't see many problems if they are losing their residual hearing, because the patients are quite okay when switching to electric only, because the electrodes are deep inserted enough.
Well, I would like to play the devil's advocate. We are proposing to use long electrodes, but right now we're very happy with 26. Baumi.
I'm not very happy because of 26. Actually, we started the Flex 26 because of the University Department of Tübingen. But if we do now cochlear implantation, and especially in this meeting we learned this, we need to change our job. Cochlear implantation in the meantime becomes a genetic business. All what we know now, and we had wonderful talks from Hubert Löwenheim and from others, we have now 250 genes already identified directly related to hearing loss, to fast hearing loss or progressive hearing loss. And if we do now cochlear implantation in a patient where we do not know his genetic status, in my opinion, this is actually a kind of malpractice, because it's not a difference if we know that this adult will become deaf in a few years because of genetic background, or he would have a genetic background which is a quite stable disease. So we need now, like in oncology, we need to differentiate a stable disease, even if it's very poor hearing, or a progressive disease. And if we have adults, let's say 40, 45, 50 years old, and we know their genetic background, even maybe if they have sensory neural genes, so genes in the background who are on the spiral ganglion, then there is no need for any residual hearing. Then it's our aim to go, our duty to go to a full deep insertion. And if we have people who become deaf, we need to have a full insertion, because only the full insertion justifies anatomy-based fitting. And without anatomy-based fitting, and we know this from thousands of papers and experience in the meantime, it's more or less useless. So we have two possibilities. We have, let's say, residual hearing for a longer time, then we can go to smaller, to shorter electrodes. If we know from the genetic background the patient will lose his hearing very soon, it's our duty to go to deep insertion and anatomy-based fitting.
Well, I understand that right now knowing the genetic is a bit too much. I mean, this may be the future. But Anya, 26 or 26 with the risk of losing hearing at the long run, or 28 or 31 just to have a complete cochlear coverage from the standpoint of outcomes, hearing outcomes?
You know, you're asking the audiologist right now. Huh?
Yeah, I know. This is why I'm asking you.
Yeah, okay. Well, then you can guess my answer. I absolutely believe that we need to have access to the apex. I absolutely believe that we need to be in place in order to stimulate that region. I mean, if there's still functional hearing, it's fantastic. We can use EAS. And the electrodes are designed in a way that there is a high possibility that we still have, you know, active cells that can take on the acoustic stimulation. But one day when they are not able to, you know, to recover, I mean, I absolutely believe in stimulating in a tonotopic correct way. That's about anatomy-based fitting. And so, yes, the audiologist says just be prepared for everything that comes in the future.
Okay, last question, Stefan.
I have a question to the panelists. How about using an electrode that fits the whole cochlea, but push it in only as far as necessary to preserve the residual hearing? And if the hearing gets worse, just do the full insertion.
Well, you get
Has somebody experience with this?
I would say you get a fibrosis around the tip of the electrode, and when you push forward, you will get in trouble maybe.
Is that true, Baumi?
Yeah.
Actually, this is what Christoph Ilberg, unfortunately passed away a few weeks ago, already told us in '99, and I don't know if Silke is in the room. Because before we had all this different length of electrode, we just had the standard electrode, and we really did that. So we just inserted the standard electrode for 22 millimeter. But to my knowledge, only not even a handful, only 1 or 2 patients later on in Frankfurt were reoperated for a full insertion. But I absolutely understand what you mean, and it's still in my mind with the nowadays electrodes, with the flex electrodes, and with all the drugs we have, with the intracochlear cortisol, dexamethasone. First, I need to mention that because we had so much dexamethasone today. I want to tell this to the audience. Actually, the best would have been triamcinolone acetonamide, which is even better than the dexamethasone, but the triamcinolone is too difficult for manufacturing on the electrode, because then the electrode would be not so gentle and soft anymore. Then it would become like a file. Yeah? So this is why we have the dexamethasone.
Okay, let's move to the next challenge, and let's travel this time from Frankfurt to Frankfurt. And here we are to meet Professor Tobias Weisgerber. Tobias is an engineer. He studied electrical engineering at the Technical University in Munich and received his diploma in 2008. He's deputy head of clinical audiology, audiological acoustic department, right? And he has been professor of clinical and experimental audiology since December 2023. His primary research focus is on speech perception, in noise reverberation, and sound localization abilities using virtual acoustics and reality, as well as electrophysiological measures in CI users and subjects with combined electroacoustic stimulation, which is your topic today. Welcome.
Javier, thank you very much for a very nice introduction. It's a great honor and privilege to welcome you all here in Frankfurt, probably one of the best places in the world to talk about EAS. I would like also to acknowledge the whole team, which of course is involved in the clinical work and also in our studies. And Piotr and the first part, so to say, of the discussion already sets the stage for my presentation. We already know quite a lot about the beneficial impact of acoustic stimulation, for example, on speech perception in quiet, also in noise, on sound quality and the naturalness of sound. And of course, maybe one of today, we are happy that in all our patients getting cochlear implants or even EAS, we not only aim at best speech perception, but of course, things like in the past were maybe impossible. Today, people are a lot motivated to enjoy also, of course, listening to music and even play music. Maybe sometimes professionally, even with a cochlear implant. And we see that EAS can be better than electric only. So we have some studies showing that, especially related to speech perception and quiet and noise. And I would like to add today some new studies with, compared to quite old studies, a little bit more higher number of cases in the long term. But I would also like to present you some quite new data in a prospective study looking into the reality, because we want to that our patients performing good in every day. And every day is, of course, adverse noise. So we have lots of noises. We have, like here, you can hear quite nicely, we have lots of reverberation, and all of the patients have to cope with that. So how about speech perception in adverse listening conditions? So speech and quiet, one of the retrospective analysis I would like to present you today is only analysis of the ipsilateral ear, so the ear getting EAS, or getting a conventional CI. We looked at the most recent appointment in a database, which means at least 12 months of CI usage in this ear, and we compared the group of CI conventional stimulation with our group having EAS in one ear. So here we have the results. You can see on the left-hand side. I try. No, there's nothing. Okay, no pointer. So you can see in the white boxes, you can see the performance with the CI, and in the grayish boxes, you can see the performance of the EAS subjects. And to sum it up, we can see, averaged over all patients, that the EAS group performs about 10 percentage points better than the conventional CI group. So that's quite already known so far. But we can also look into the performance doing speech tests and noise. Again, a retrospective analysis of a clinical setup, so speech, noise co-located at the front. Again, only test of the ipsilateral ear, so the implanted ear. We looked at the most recent appointment, and we have data of more than 600 patients having a CI, and compared this with a group having EAS in the implanted ear. And you can see also quite nicely here that we have better speech perception and noise in this ear, about roughly 1.5 dB better having the EAS system compared to our CI subject group. So that's basically the data which can we find in our quite long established database. Now I have some new data and prospective analysis. Now we are going a little bit more into reality, so we try to split up the positions where noise and speech is coming from, and we are also incorporating now reverberation with a 128 loudspeaker setup to simulate, let's say, a quite badly designed classroom, so like you can typically unfortunately see in Germany. So now we are in the reality, so we're doing binaural testing. So we also tested again additionally with the second ear, because that's what we need in every day and what's important in every day, to have cues from both ears to do binaural hearing. And we compared 3 subject groups having CI or EAS with a normal hearing group. So lots of data here in the slide. Shortly, you can see in the white boxes here, we have free field tests. Now we are using modulated noise, so which is more related to everyday, like speech, but without any informational content. So this is in the white boxes, and then we have in the gray boxes the same test, speech and noise separated by 60 degrees and additional reverberation. And firstly, the bad news, so you can see quite a high difference between the CI groups and EAS groups, between all and the normal hearing groups. So in this adverse listening conditions, we have still a very, very big gap between normal hearing and CI or EAS hearing. But the good news, if we are focusing onto bilateral CI versus bimodal hearing or bilateral hearing with ERS, then we can see quite nicely that also in these adverse listening conditions, hearing is better when having at least one ERS system with additional acoustical hearing in another ear, and also as good as this bimodal hearing when we have ERS even in 2 ears. So that's the good news. And yeah, I skipped the summary. I try a short simulation. I hope that the audio playback will work. So now we get like simulation. This is not really hearing with a CI, but it goes in this direction without any brain plasticity, so to say. So that's the sentence only with CI, electric only. Then now we are looking or hearing only at the low frequency, low pass filtered sound. And now we add these both modalities up to one combined ERS, and hopefully you can understand it the best way. All right. Thank you very much for your attention.
Okay, from the engineer perspective, your experience is that EAS is preserving the long term, or what will be the percentage of patients losing the electro-acoustic stimulation and just relying on electrical stimulation?
So I can recommend all that here at the conference until the end. The last session at Saturday, it's the graphical clip session on CIs, where Mariana Bandera are presenting data on long-term stability of residual hearing. So basically what we see is that after 3 or 5 years, of course, we see the first drop in hearing directly after surgery. Then we have, in most cases, many cases, quite stable residual hearing for the next, let's say, 3 to 5 years. Of course, as we already heard, it really depends on the etiology. But on average, you can see 3 to 5 years are quite stable, and then you are trying to lose more and more of the patients, but even in the long term, so looking at 10 years and later, we can see that nearly 70 to 80% can still benefit from at least a little bit of acoustical hearing.
Okay, so from your perspective, not being a surgeon, short electrode, I mean 26, the discussion we had before, or 28, 31?
So we shouldn't have any gap between acoustical hearing and electrical hearing. So as long as hearing will be preserved quite good, then it should be right at this point. So we have to look preoperatively to find the best place, and then the surgeons have to do their best to preserve hearing, and then we have the best combination.
But if this distance is 26, then if the patient loses the acoustic stimulation, it's going to be a short electrode. Well,
it depends on what you are comparing, between which kind of electrodes you are comparing, especially looking to electrode lengths of other manufacturers. So I would say having a full 26 insertion is still quite good, even if you lose your residual hearing.
Jörg.
Well, just a comment. So the biggest problem, I think, is when we do surgery in a patient with significant residual hearing, and the patient loses this hearing immediately. Then it's a disaster, because people are getting crazy, because then they have just the electric stimulation. If they lose acoustic hearing over time, after 3, 4, or 5 years, sometimes they don't even realize that they lost it. They just come to you and you do the testing and say, hey, something happened. And says, yes, but I'm well adapted to this new situation. So I think we have to keep this in mind as well. And therefore, when we do surgeries in patients with residual hearing, Otoplan is a wonderful tool which can help us to find the right length of the electrode. But as I told a few minutes ago, I wouldn't go under the limit of 24 millimeters. Because then it's difficult to adapt for the brain in the long run.
Yep.
From the engineer point of view, I asked them in our team what they think is the really important, I think, to preserve hearing, to have good stimulation. And I think recently you can see in publication there is a lot of discussion about impedance. There is issue about the distance between the electrode and the modulus, and also there is very nice 2 publications about post-mortem studies about the structure preservation. So we would like to go according to Otto plan. We would like to go according to the length. But if we, for example, make a little bit longer electrode, and we go with insertion and we have significant resistance and we cannot go through, there is the question in all of us to go deeper or not to go deeper, to go step out and step in. That's what I suffer from, that is the diameter of the scala tympani, which we know is a little bit smaller than the diameter of the electrode in the apical region. That's why I would not go with more than flex 28, because I suffer from that not today, but later the impedance will change, the production of the new tissue in the cochlea will be worse, and in the time we could lose the hearing. I agree with you that after 5 years, there is an 80–90% even people who have preservation of the hearing, and also with Georg we said, if we don't lose the hearing immediately, if the patient has decrease of the hearing loss in the time because of the like presbycusis situation, patient could adapt to that situation. And even if the patient will lose with flex 24, with fully deafness after 10 years of the surgery, they would have really nice benefits. So this is important to combine audiological outcomes, size of the cochlea, and that's what we do during the surgery with different length of the electrode.
Tobias, go ahead, Baumi.
I just want, it's a short statement. Sometimes, and also in this conference, I got the impression that impedances are a sign of quality of cochlear implantation itself, which is definitely not the case. Impedance is a pure physical parameter of how much electrical energy makes a certain physical reaction. So that means if you have a lower impedance in a patient or a high impedance in a patient, this does not say anything about the quality of the signal in his hearing nerve and in the brain. It's just a question how much electricity you need for a certain physical outcome. So if you have higher impedances, you need more electrical energy and your accumulator or battery will end earlier. But you can have, or you will have, absolutely the same physiological outcome in a higher or a lower impedance. And I think I just want to state that.
Tobias, one last comment. The fact that the patients with electroacoustic stimulation may do better than those with only electrical stimulation supports the need to stimulate the apical part of the cochlea with electrical stimulation? Or this is just a stupid surgeon's idea?
Well, yes. So
a stupid surgeon's idea, yes.
I definitely agree, but still the modality is different. So we have to come with the pure electrical stimulation. If I need to use electric only, it should be as close as physiological acoustic stimulation. So maybe, approaches like fine structure processing could be a good approach to come closer to acoustic hearing.
Okay, let's move to the next trip, and now we're traveling to Vienna. Okay, and here we are with Baumi, Professor Baumgartner. He was the professor of Oto-Rhino-Laryngology at the medical faculty of the Vienna University and the head of the ENT department and senior physician at the Vienna ENT University Hospital. He was elected the new president of the Cochlear Society recently in 2020, and he is currently our general secretary at the hearing group and will tell us about single-sided deafness in children. Baumi?
Professor Gavilan, thank you so much. We make a long story short. Let's say single-sided deafness, cochlear implantation, make me learn a lot in the last 15 years. So our philosophy and everything changed in the last years, in the decade. So our minimum audible angle in humans is 1 degree, in the Philharmonic Orchestra even better. And until 15 years ago, until Joachim Müller and until Paul van der Heining in 2002, there was even neglected that single-sided deafness is a disease which needs to be treated. And of course, we want to treat single-sided deafness. But it's not successfully possible in adults in all the cases. And in children, I want to show you that it really works. By the way, we all know that bilateral hearing is not a genetic function. So bilateral hearing needs to be learned, and there is a point of no return in the year 7 or 8. These are the clinical data from Würzburg and Vienna, and these are the objective data from Anu Sharma. She's now in Denver. And of course, we have some options in adults, also in children, in single-sided deafness, with hearing aids, with the bone bridge, and of course, with the cochlear implant. But if we want to restore the organ, if we don't want to have a pseudo-bilateral hearing, then only a cochlear implant will work. With all the bone conduction devices, we will only produce a pseudo-bilateral hearing. So in Vienna, we had quite a number of old Baha patients, single-sided deafness, we have adult single-sided deafness, and we have now 12 single-sided deafness children, all malformation kids, who have a bone bridge, and they are now implanted up to 13 years. They do very well, but they do not do like cochlear implant kids. And the first single-sided deafness patient with a cochlear implant, because of his hearing loss, not because of his tinnitus. Tinnitus was Paul van der Heining, hearing loss was Joachim Müller, was done in 2007, and I did 2008, the first adult in Austria. And maybe it could easily be that in 2011, March, I did the very first single-sided child with a cochlear implant in Vienna. Now we have over 20 school children. The youngest kid is 2 years old. And what we see, the problem is, how do you define single-sided deafness? Many of the children, also the adults, they have even a completely normal contralateral ear, or they have some hearing loss to some extent. So that means we have not, this single-sided deafness is not a clear definition. This is what we really need to define, how good or how bad is the healthy ear. And if we do cochlear implantation in pediatric cases, it's mandatory to see the eighth nerve. This is absolutely mandatory. We need to see the hearing nerve. We need to be sure that it's there. We sometimes have cases where we do not see the hearing nerve, and then we even do a second MRI, and you will not believe how different the outcome can be on the same kid if you have different MRI sequences in different departments and different MRI machines. We have proved, and this is published already, that with bilateral hearing, with cochlear implant, actually our patients are the single-sided deafness patients. They behave like normal hearing patients. This is all data. It's all published in the meantime. And I changed my mind dramatically. In 2023, I had the honor in Hanover 2 years ago at the German ENT Society meeting. I had a big lecture about single-sided deafness, and I said there in 23, single-sided deafness babies are still study program, question mark, question mark, question mark. 2 years later, I want to tell you, single-sided deaf babies, if they have a hearing nerve, yes, 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 do the implant. This was my personal learning in the last 2 years. So if we have single-sided deaf children, not malformation cases. I don't speak about malformation cases. If you have single-sided deaf children, we need to do a genetic workup. This is also very surprising what we found. This will be at another occasion a nice talk. If we have infants, school kids, please do the cochlear implantation. Very important is the expectation. And what is very important, because I had from the United States last year, there were some papers out that single-sided deafness surgery, cochlear implantation in children is useless. And I want to state it clear now in the internet, this is wrong. Because when do you have a good result in single-sided deafness? You need rehabilitation. A single-sided deafness cochlear implant is not like glasses. You don't just give it to the kid and will say, okay, he will learn reading anyway. This does not work. Single-sided deaf children need rehabilitation, and they need the same rehabilitation than bilateral deaf children. This is very, very important. Also important is the fitting. We need a really good fitting. We need good engineers, and we need a long and deep insertion, and we need anatomy-based fitting. If I looked at all the papers from the US groups, and I talked, for example, also to Oliver Dunker, and the big problem in those papers stating that single-sided deaf cochlear implantation in children does not work are 3 points. First of all, the post-op care in rehabilitation. Secondly, the post-op care in programming. The green button on the auto program does not help you in single-sided deaf children. You need to have an active engineer working with the child and working with the speech therapist. Then you have a good outcome, and you need fast stimulation. So you need more than 50,000 stimulations per second. This is very important. With a very slow stimulation and a lousy programmed implant, you will not have good benefit. What we see now in 14 years, we can show that single-sided deafness is working. In our Vienna kids and also in a lot of European kids, we see that the results are really good. In our pediatric population, we have 100% cochlear implant users in single-sided deafness. We can show that it works, and now, because of this, we recommend cochlear implant rather than any bone bridge and pseudo-bilateral solution, and you need deep insertion and fast stimulation. This is it in 5 minutes. Thank you very much.
Thank you, Balmi. Well, from all the topics, challenging topics we're discussing today, I think the single-sided deafness in children is probably the most controversial. Balmi, is there, you said in your last slide, any age, does neuroplasticity play a role in children? I mean, a single-sided deafness child, 5 years old, with a very good nerve, is a good candidate for a cochlear implant?
Yes, absolutely. Absolutely. It's a super candidate. So we were very cautious. We were really very cautious. So the first child I implanted was age 10. And we need to differ postlingual children, of course. Postlingual single-sided children, they behave like postlingual adults. That's not the problem. The problem are the prelingual congenital children. And it's also interesting what we found in the genetic workup. So, for example, I just say it now, for example, connexin 26 obviously has a lot of clinical appearances. So you can have a connexin, there are some subtypes of connexin 26, and the child is on one ear hearing, on the other ear it's not hearing. So just for example. And it's very important to see the hearing nerve. But if a 5-year-old congenital single-sided deaf child with a normal control of the hearing is a good candidate. And the physiology helps us a lot because the hearing tract, so the hearing fibers, because they are crossed, we have a physiological crossing of our hearing fibers in the brain, so they do not start at zero. It's more or less the same. It's a similar situation to a bilateral deaf child who was implanted, let's say, age 6, 7, 8 months old, and then on the other side implanted as a 5-year-old. So actually the behavior of those kids is those sequential implanted congenital deaf kids who were babies. Yeah? So this is very, very important. So I hope...
If it's not 5, if it's 10, you will do the same?
Yeah, this is a very good question. So we are now, at this moment right now, we are testing this, yes, because the results were so promising and actually so satisfying. Yeah, the results are satisfying. So we now go up and up. And we have already some 10, 12 years old. On the other hand, to be honest, it's extremely difficult to see the anamnesis. Because we had for some years, we had in the Austrian newborn screening the stupid idea just to screen 1 ear instead of 2 ears. And we have not consistent data as we would like to have in some of the children coming to us. But I see also kids who passed with Oto-Acoustic emissions the newborn screening, and now 12 years later they are deaf on 1 ear. So the anamnesis is really crucial. So I cannot really claim that all of them are maybe really congenital. Yeah, so the congenitals are usually those, let's say, age 0 to 5 or 6. But what I do now, really, what I really want to recommend, if you have a 1-year-old child, 2-year-old, and you have a good hearing nerve, you have no malformation, you do not know the etiology, whatever it is, then do the cochlear implant. It's really worth it.
Do you think the same, Piotr?
Our material is, single-side deafness is, I think, 600-700. I will go up to 20, 30 years with congenital single-sided deafness, but it's not easy. It's really meticulously heavy counseling. I think that Kevin Brown, there was very tough discussion in the spring meeting in American Otological Society about that. If there is nerve, or if there is ABR response in frequency specified ABR, we would go for that. But we know that each year is worse, so there is very heavy counseling. Earlier we had a little bit more non-users, especially in patients after months, which was obviously not congenital. But today, vaccination is a different story. I will not talk about that. But we have some patients where we are not sure about that if they were fully congenital deafness. And we go for that implantation after counseling because the results are better than with one conductive device. If you have ossification, you have not good situation there, no nerve and no response for ABR, then we go for bone conductive device. Always we propose that, but this is the problem. And sometimes if we see that the patient is not prepared, so we have something, we could go, parents are not prepared for rehabilitation, we would not go for that because we see that they are users, but they are not, I would like to say semi-users. They use it only in the special situation, and it's the good direction not to use in generality at all, and they mainly use it because there is tinnitus. And that's what was mentioned. Patient without single-sided deafness or asymmetric hearing loss without tinnitus is always better than patient with tinnitus in our material from the hearing performance after the surgery.
Well, I think that the use of bone conduction devices in children doesn't really play a role. I mean, the situation is completely different between adults and children. In adults, you can choose to hear Georg from your right side just by using a bone conduction device, but this is not what we want in children. What we want in children is to have a binaural rehabilitated patient. And therefore, bone conduction devices in children, I don't think you need a test of bone conduction device before going for a CI, if you are deciding a CI. Anya? No.
Maybe I can add from what we've learned from SSD in adults from an audiological point of view. So what we see is that even if they got their single-sided deafness by sudden hearing loss with short duration of deafness, we see that SSD patients are sometimes on average worse than all other CI groups because they are used to use the other ear. And as Piotr said, the duration of device usage is shorter. The loudness is typically a little bit softer than the normal hearing ear. So it's quite hard as an audiologist to get it really balanced. As long as they are not adapting the system as being a second ear and a second part of it. So that could probably support the idea of in children do it as early as possible so that the children, they are growing up with 2 ears, and they don't see the CI just as a second, not equal system like the first ear.
Last question from the web: what happens with these children when they become teenagers? Will they continue using their CI? Piotr. Quick question.
In general, teenager is the worst time for making any intervention of surgical, So either we do it.
The question is, if you put it when they are 5, what happens when they are 15?
And this is exactly what I wanted. So we try to avoid the surgery there, but we observed in the group, because we have some years experience in that, and when they were a young teenager, when we implanted them, when they're 10 years old, then there was a little bit decrease. But we see motivation when they go to university, the patient, they increase more. So the patient with single-sided deafness implanted, the lowest rate is in teenagers. So in teenager time, they could use it less because of the social issue. But they need to use it at least some hours per time. So if we have patients when they say, my daughter would like not to use that. I said, give them chance to use it 2 hours, 3 hours, maybe at home, not to, to lose contact with the nerve. And they will use it in the university. I think after 5-10 years, we have such observation. But this is the worst time for the wearing cochlear implant.
Okay, last flight. We're now flying to Germany, to Würzburg. And we are here to meet Anja Kurz. Anja is the technical lead at the Comprehensive Hearing Center of Würzburg. This center runs a large hearing implant program covering all the implantable hearing devices and conducts up-to-date research on fitting topics, hearing performance with cochlear implants and middle ear implants in adults and children, as well as the intraoperative monitoring. Anja has over 15 years of work experience in the hearing industry, and she's an active member of the hearing group. And you are going to deal with a very amazing topic, digitalisation in cochlear implants follow-up. Anja?
Thank you. Thank you for the kind introduction. And we are slightly changing topics right now because we are always a step ahead. So let's introduce digitalisation in cochlear implants follow-up. So why is this topic so important? So this is the clinic, this is the team that I'm working with, and the Comprehensive Hearing Center in Würzburg sees itself as an interdisciplinary integrative center for diagnostics, consulting, therapy, research, and training in all aspects of hearing. We do a lot of intensive and effective basic research, but we have a high focus also on applied medical technology and clinical care research. We are dealing with cochlear implants, middle ear implants, implantable bone conduction devices, and auditory brainstem implants. And of course, we have an adults and pediatric program and many cooperation partners. So, why is this important? So, the general framework that we are working in here in Germany is that we have to follow the guidelines by the White Book. We are certified as CI dealing agency, so we have to pass an audit every 2 years in order to get certified to be proven that we follow all the guidelines and that we have a high quality standard. So what does this mean? There are some basic stones that we have to follow in order to get certified. So there are rules that we have to follow in terms of the preoperative evaluation, the kind of surgery we're doing. Then we have the follow-up care. We have the basic therapy, the follow-up therapy, and the lifelong aftercare. So these are the stones that we have to follow, and they are requested by the CI White Book. So the question that comes in now is, where do all these digital or remote services might come in? So I'm not talking about the aspects that we are now going remotely into the OR to check the implant functionality. So I leave this out because I want to focus on the CI aftercare. I want to focus on what we're doing with the patients afterwards. So, of course, there are many, many parts where we can introduce digital or remote services. The idea now is to focus on the follow-up therapy and the lifelong aftercare. So here we have now the possibility to not only use remote check, but also provide remote fitting across all the CI manufacturers. When some of the manufacturers, or pretty much all of them, came to me about 2 years ago and said, well, we have now these nice functions, just use it. You're saving so much time, and your patient, of course, is also saving so much time. We were like, well, sounds interesting. Let's see and let's provide the proof if we are really saving time by doing that. And there were a couple of challenges when we're starting to think about introducing remote digital services. The most important question, reimbursement. Who is going to pay for that? If we don't ask a patient to come into the clinic, if the patient can stay at home. So can we earn money with that? What about the reorganization of the clinical schedule? I'm going to present you the clinical schedule, the aftercare, just in a minute. And the idea was, well, how can we bring it in and how do we introduce all these remote services? Then staff. Is everybody happy in the staff to do that, to provide remote services? And what about the patients? Are they ready to do that? Let's see. So this is the schedule, the follow-up schedule that we have in Würzburg. So 4 weeks after CI surgery, we are activating the CI on 2 days. This is called Erstaktivierung in German. Then we have the routine to see the patient after 1 month, 3 months, after 6, and then 12 months have passed. And then we go over to the yearly checks. So this is our idea, our concept of aftercare for every CI patient. So where would you bring in remote services here? So in order to monitor what we're doing and to actually have the evidence afterwards, we have installed a big study and we have created 2 study groups. One is the remote group and one is the clinical group. So the final endpoint is for both study groups the 12 months appointment at the clinic, because this is an important date. This is where we have to measure speech understanding and quiet noise and so on, and provide those data to the registry, because we have a CI registry in Germany, and these are important data in order to show the performance of our clinic and the patient. So in order to bring in remote services, we decided to recruit patients at their 3 months appointment when they come into the clinic. We asked them, would you be interested to have your follow-up for the 6 months appointment remote and additional a 9 months appointment remote? And then we see each other again at the 12 months appointment at the clinic. So people could decide if they wanted to follow the one group or the other one. So this is the remote group. The other one, the clinic group, of course, big appointment is the 12 months appointment. And the patients in this group, they come into the clinic at their 6 months appointment. They are offered an additional 9 months appointment also at the clinic. And then we check again at the 12 months appointment. So the study questions that we wanted to answer is remote follow-up, and this includes fitting and speech therapy. Is it effective and goal-oriented for patient and acousticians or therapists? And what is the need and the motivation for remote follow-up? So we have 2-arm parallel study groups, and we include all newly implanted CI recipients with all brands. We, as already stated, we recruit at their 3 months appointment. We use the remote check technology as it is, as we get it from the different manufacturers. We do provide remote fitting, and we do have the speech therapists involved to monitor the progress, and of course, questionnaires. Endpoint is the 12 months assessment, and here we provide the checkings, or we assess the check, the remote check data versus the audiological data measured at the clinic. So you're the first to see the first preliminary analysis. So we started this study in autumn 2024, and we asked 58 patients if they wanted to participate in the study. And 29 of them declined. They said, I don't do studies or whatsoever. That's okay. But there are 29 that confirmed. So this is the state of last week. And of course, during that week, there are more patients that were asked already. So from that starting point, 16 decided to follow the remote check, the remote group, and 13 decided to stay in the clinic. And now you're going to ask, who is in the remote group? These are the youngsters, right? Okay, let's look at the ages. Well, the age range in the remote group was 27 to 76, and in the clinic group, 29 to 80. So, no. So everybody's interested in doing that and having a go. So this, as I said, we are doing it across all the manufacturers, and you can see here with which manufacturers we are using the technology as is. Via apps, we are remote fitting, whatever is accessible. So what was the motivation for the clinic to follow, to come to the clinic, to go into the clinic study group? Well, they said the motivation to stay in that group was they wanted to see the doctor regularly, and they wanted to see a face in the same room. And some of them had a fear to get acclimatized to the CI. What was the motivation to go into the remote schedule? Well, of course, not to find a parking space, because that's like everywhere a challenge. Well, of course, there were people technically interested, and some of them said, okay, they wanted to have the maps checked after rehab. Okay, interesting. And some of them said, well, you have a quite long span between a 6 and 12 months appointment, so it's good that at 9 months appointment we can have a checkup remotely. So we started that, and I'm going to tell you what's happening, at lunch break in the clinic's kitchen. When the clinicians come in, when the audiologist comes in, and the speech therapists. So the days when lunch is great is when technology works, when the internet connection works. So there everyone is very motivated. But sometimes, they come in and said, well, although we explained the technology, we installed the apps, we provided guidance and everything, like for dummies, for some of the patients at home, this is just too much. So this instruction process is sometimes a bit too much. However, the speech therapy works great, so they are all really enthusiastic. What are the challenges? Well, the challenges that we see at the moment is, what about the magnetic strength things? These people are at home, so then they have to come in to the clinic. What about if they say, well, I have a pressure point here, there's the scar that itches and so on. Well, this is the point when we have to say, well, you have to come to the clinic, okay? We noted that, but you have to come. So, as already stated at the beginning, our idea in the Comprehensive Hearing Center is to have a high-quality standard and to deliver a personalized, patient-focused aftercare program. And for some of the patients, it's in a clinic, and for some of them, it's at home. So our experience so far is implementing a remote service is a challenge. It is not really straightforward. And something important to note, that technology and the function in apps is not comparable across the CI manufacturers. In some it works fantastic, and in some of them there are some issues that come up because we use it, and it seems that not other clinics are using it, which is interesting. So maybe in the future, when we are in control of all these remote services, we are in the process to save time, but we are not there yet. So there are more data to come, and if you're interested in hearing about our experience and hearing the outcome of these studies, we will have a huge event this October. It will be held in German to talk about all those aspects of remote CI care. Thank you.
Thank you very much, Anja. Well, this is a real challenge. I mean, we've been dealing with challenges, practical challenges, but this is a real challenge. And there's only one thing I miss from your presentation. This should be related to artificial intelligence. I mean, the only way we can manage all the data you're going to live with this big data situation should be managed with artificial intelligence. AI should say something. Are you thinking about that, or is just one more of my stupid ideas?
Well, I believe we are not there yet. At the moment, we have to collect all those data and learn and see for which patient is this the right approach. I mean, we cannot generalize. And of course, we are collecting a lot of data, and I'm sure that some AI algorithm wants to learn with that. But at the moment, we are more interested in providing the best care for every individual. So I think there are some steps that we have to follow first, and that we have to learn and understand first.
Okay. Well, if we don't have more questions, this is the end of our roundtable. And may I have the slides? The few last slides. This is our last meeting in Dubai, last 2024. We have, if you visit our webpage at www.hearing.com, you can have nice tools for everyday's practice. The hearing preservation calculator, the counseling platform, or the feeding tool. Those are very useful tools. If you want to endorse the hearing health initiative promoted by Professor van Heining, you are very welcome. You just visit our webpage and endorse this initiative. There, in our webpage, you can find quality standards in adults, children, and older adults. Those have been updated and summarized and are a very useful tool also for those of you interested in hearing implants. And if you visit the boost.hearing.com, you will find all kinds of courses, lectures that are recorded, available, and free. You have everything from expert lectures, courses on otosclerosis, image-guided surgery, everything, as well as these roundtables. And these roundtables and all roundtables are accredited by the CPD organization, and you will get, it takes a bit of time, about 6 weeks, but if you write to boost@hearing.com, you will get your accreditation. As you've seen here, Hearing Group is a very active group. We are now in Frankfurt, we'll be next month in Hanover, in Rostock, in June also, July in Béziers, October in Kuala Lumpur, in October also in Naples. So we are very active, and you are invited to all our hearing roundtables. And for anything you want, you need, please send us WhatsApp, excuse me, an email, a question, comment, whatever you want to our webpage, and we will be more than happy to answer your questions. And without further ado, thank you very much for being here. Thank you very much for the people online, and we wait you in the next hearing roundtable. Thank you very much.